Hello and welcome to this WebEx. My name is Robert Benedict. I'm a senior product manager with the orthobiologics team at Arthrex, and I'm here with Christian Bezener, director of medical education at JRF Ortho, and he is here to present to us the indications and surgical techniques with fresh osteochondral allografts. Christian, thanks so much for joining us.
Thank you, Robert. Pleasure to be here. Thank you for the opportunity. We'll spend a few minutes, as you said, going over some indications and surgical techniques. Obviously, with Arthrex, you have tremendous access to multiple surgeon partners, and so you hear this from the experts themselves. This is a bit of an opportunity to give you perspective and point of view from one of your tissue providers, one of your tissue partners, in terms of how we view these specific subject areas. So with osteochondral allografts, obviously we're talking about a highly complex tissue with hyaline cartilage that does not heal itself once injured. And really the sort of current concept, current thinking with most surgeons when they're talking about these articular lesions is that the treating the knee as an organ and really looking at the cartilage as part of a unit. And so, from an analogy standpoint, I like to think about, if you think about the carpet that you have over a floor itself and then the subflooring. If your carpet wears out for some reason, something gets spilled on it, gets torn, something like that, and it's just the carpet itself. If you replace that carpet, that area is fine. But in many cases, if it's the subfloor underneath that's collapsing, and that's why the carpet is wearing out, you can continually replace that carpet, but it won't ever function, right? Because you've lost that subfloor. So for osteochondral allografts, really the concept is that this is a lesion that involves those different layers, that entire unit, to include the subchondral bone. And if that bone is diseased, if that bone is collapsing, that's really probably the reason in many cases that the cartilage then has started to show wear and tear, if it's still present at all. And so the idea, if you look at it from a treatment algorithm standpoint, and this is another one of the huge advantages to Arthrex, is Arthrex has put together a world-class portfolio that gives surgeons and their patients options across this entire disease spectrum. But when you're talking about osteochondral allografts, you're probably talking about that far end of the spectrum. These are larger defects. These are disease processes that have probably been in process or present for quite a while and have now started to manifest themselves in pain or whatever symptoms brought the patient in the surgeon's office. So from an overall indication standpoint, again, we're thinking larger, we're thinking involving cartilage, tide mark, and subchondral bone. And those disease processes typically include things like osteochondritis dissecans or OCD lesions. They could be traumatic, acute traumatic lesions, avascular necrosis or AVN, or salvage based on previous cartilage surgeries. So there's more and more data in the literature now to suggest that osteochondral allografts are still a very, very viable, still a very, very successful option for treating prior cartilage surgery. So the surgeon has responsibly tried something else as the disease process was younger, and it has not necessarily burned any bridges for that surgeon or that patient to go back and attempt an osteochondral allograft then to address. Contraindications would be more widespread autoimmune or degenerative joint diseases, or osteoarthritis that's just diffuse through the joint. In terms of discussing indications and surgical techniques, I'll reference a couple of times our MOCA group. MOCA stands for the Metrics of Osteochondral Allografts. And this is a group of select surgeons, thought leaders who have come together to really study the questions still out there around osteochondral allografts and to help get more information out to the community, the surgical community at large, about the appropriate use of these grafts, the right indications, the surgical techniques as they're evolving. What should surgeons be thinking about and doing when they're considering using this in their cartilage treatment algorithm. And this is just an overview of some of the surgeons involved in this group. Very recognizable names, thought leaders across sports medicine and orthopedics in general, but specifically with osteochondral allograft as well. And specifically pertaining then to indications, I went through a process of developing MOCA consensus statements a couple of years ago. And these were the consensus statements that were agreed upon for this specific area of indications. As we just talked about, OCD, trauma, those types of lesions are perfectly appropriate for this intervention. The relative contraindications we just went through as well. Also talked about the concept that these can be used to revise previously failed cartilage procedures. This is, however, it's not, osteochondral allograft are not just a salvage procedure as maybe historically was thought. These can be considered as a primary option for OCD lesions, and the systematic autoimmune inflammatory disease is not necessarily an absolute contraindication. From a surgical technique standpoint, this is something that the Arthrex reps, many of them are very, very familiar with. The concept is coring out and removing the diseased cartilage and subchondral bone, and then taking the donor condyle and cutting the same plug to fill back in that void that's been created. The ultimate goal would be the subchondral bone behind the cartilage is what heals and incorporates over time, and then you've now replaced a diseased articulating surface with healthy cartilage. As soon as the joint is closed back up, the synovial fluid is back in the joint, the cartilage functions as it should, and you have a quieter, happier knee for the patient moving forward. But the basic surgical technique from that standpoint is a round plug historically cut to remove the diseased cartilage and replace with new. Some innovation and some surgical technique evolution over time has involved addressing more oblong lesions, and these would be more on the articulating surface of the femoral condyles, but when the lesions are longer in the AP dimension than they are in the width, surgeons can address those lesions with the snowman technique or using multiple round plugs. That's technically a bit more difficult. What Arthrex has done to address that is really come up with a unique new system called BioUni, obviously, that's used to treat those oblong lesions in one single plug. JRF also supplies pre-cut osteochondral cores. Those are still fresh, viable, cold stored grafts. Those come in 10 and 16 millimeter pre-cut sizes. That's as close as we get in this arena to an off-the-shelf option. Those are implanted with disposable Arthrex instrumentation. So it really cuts down from a technique standpoint. It really cuts down the surgical intervention to just creating that socket in the patient, trimming the core to the depth necessary, and then implanting it with the disposable Arthrex instrumentation. Going back to the MOCA group, from a surgical technique standpoint, the consensus statements had to do with the fact that supplemental fixation of these grafts is only needed if the surgeon feels like it's required. And those could be lesions that are somewhat uncontained, falling off into the notch type of thing. But typically, interference fit is more than enough to allow for these grafts to be stable and to heal. If there's any cystic formation as they're creating the socket in the patient, use curettage and bone grafting to address that. This is a somewhat new concept in terms of the depth of the graft, but the consensus statement really was that the surgeon should be shooting for an overall depth of 6 to 10 millimeters. That does include the cartilage. It is unknown at this point if biologic enhancements are positive in terms of increasing incorporation and bone healing, but it's definitely an area of interest in further study. And pulse lavage should absolutely be used prior to implantation of the graft, just to make sure that any remaining blood and lipid or bioburden from the donor is removed to eliminate any inflammatory response and is part of the healing. Thank you. I appreciate, Robert. Are there any questions at this point?
Christian, great presentation. Thanks so much. Actually, your analogy on the subfloor and the carpet was great. Really interesting, especially when you were talking about treating the osteochondral unit. But at the end of your presentation, it kind of leads into that subfloor concept of, you mentioned the role of the depth of these OCA cores. Can you provide a little bit more detail? Why is that so important in what we know today?
Yeah, it's a great question. I think historically in this area, the depth of the plugs tended to be a little bit more, say maybe 10 millimeter plus, 12 to 15 millimeters. That's just a lot of bone to ultimately that needs to incorporate and heal. And so you may be delaying that healing pathway by putting too much bone in place. Now, on the other end of the spectrum, there was a recent paper from Andreas Gamal speaking to the fact that too thin of a plug, potentially you lose a little bit of that interference fit, and there may be some micromotion there that can lead to cystic formation on the back side, the underneath side of the plug. So consensus again from this group of experts and thought leaders is that overall depth of 6 to 10 millimeters eliminates an overabundance of donor bone that needs to incorporate, but it still allows that mechanical stability at time zero to allow the patient to go off and heal.
Interesting, thank you. So you at the tail end of your presentation, you also mentioned the role of biologic additives. Why is there so much interest in that space, and what are folks doing to consider how to best approach this?
Yeah, there's a lot of ongoing research there, because the concept is, as I said, that the consensus statement right now is that the data is inconclusive. That's not because there's a lack of promise in this area. It's really just that the science continues to emerge. These grafts will ultimately fail if they fail in a relatively small number of cases, because the bone does not seem to incorporate and heal appropriately over time. And so I think the concept of doing anything that the surgeon can to safely and cost effectively increase the chances of that bone appropriately healing is something that's very, very important to continue to look at down the road.
Great. Thank you so much, Christian. This was a very informative presentation, and we certainly appreciate your time. Thank you very much.
Thank you.